I am Geri Young. I am a retired pediatrician, and I've got very interested in physician well-being issues for many years. And I'll just tell you a little bit about myself and why I got so interested. I'm currently the executive director for Pu'ulu Lapa'au, which is the Hawaii program for healthcare professionals. I grew up here on Oahu and went to St. Andrews Priory, then went to college in Southern California, where I graduated from Pomona College. And then I came back to JABSOM to get my MD, and that was in 1978. So you guys can figure out how old I am. I'm 72. At JABSOM, I met my husband, who became an ER doctor. I went to California, did my internship in pediatrics, came back to Honolulu, finished my residency at Kapiolani in 1981, and then moved to Kauai, where I practiced for 42 years. I was primarily a pediatrician for the first 25 years or so, and then the last 15 years or so, I was a physician administrator for Hawaii Pacific Health. I became interested, and as well as my husband, in physician well-being. He was an ER doctor. We got married in 1981. In 1986, he required treatment for alcoholism, and there was really very few resources. And thank goodness there was a physician in our group who was in recovery from alcoholism, and he helped us figure out where to go. Our little group was very supportive. Our group had maybe only 25 doctors. I was shockingly the only female, but that's how things were in early 1980s. My husband did well. He had to go to a treatment program on the mainland, and he came back here and helped many, many other physicians. And I, as I said, became very interested in physician well-being. I did serve as the chair of our Physicians Health Committee for 12 years at Wilcox Hospital. And then I was asked in 2012 to serve on the board of Pu'ulu Lapa'au, which is our Hawaii program for healthcare professionals. In August of 2023, I was asked to take the executive director position after I had retired. I'd been retired for about a month because our executive director, Mr. Ted Sakai, had suddenly gotten ill. So I took his position. So I'm here to tell you this is a great program. There are 47 physicians' health programs in 47 states, plus the District of Columbia. So there are actually 48 in our country. There are 3 states that do not have physicians' health programs. I believe they're working on establishing them, and that's California, Nebraska, and Wisconsin. Next slide. Thank you. So how did this program get started in Hawaii? In 1983, the Hawaii Medical Association established a committee on physicians' health. This committee consisted of a dedicated group of volunteer physicians who assisted and monitored their colleagues in need. But it became clear to them several decades later, in October 2006, they needed to make sure that this program was separate from the HMA. So 501c3 was formed, which was called Pu'ulu Lapa'au, the current Hawaii program for healthcare professionals. Next slide. So we primarily do advocacy for our providers, education, information, and consultation, and it does fulfill Joint Commission accreditation requirements. Next. So as I had mentioned before, it is an independent 501c3. There's no formal relationship with any state licensing agency. no formal affiliation with any medical society. It's comprised of 12 volunteer board members. As you can see, the distribution of who is on our board. There's the executive director, who's myself. Our medical director is addiction psychiatrist, Dr. Angela Guff, and we have a program coordinator, Marianne Lenz. Next. We do serve quite a few providers, as you can see in this listing. We serve any licensed healthcare provider in the state. This is not necessarily true with the other 48 physicians' health programs, and perhaps it should be called providers' health programs. But many of the other states do serve more than just physicians in their PHP. Just so you know, we are part of the Federation of State Physicians Health Programs, which has an annual conference. I believe they were started, the FSPHP was founded in 1991. Also in this country, there's a Federation of State Medical Boards, and they usually meet concurrently for one day, just so that communication's really good. So we have a great relationship with our Hawaii State Medical Board. Next. What kind of conditions do we deal with? Primarily substance use disorders, but many other issues, mental and physical conditions, including cognitive disorders, behavioral health, boundary violations, including professional and sexual misconduct, stress management. Next. Monitoring agreements, there are three types: substance use disorder, medical, and behavioral. And the duration of these monitoring agreements varies from 1 to 5 years. Next. Our expenses, client organizations, we have a great relationship with all the major hospitals in this state who really financially support this organization. That is how we don't have to use clients' licensure fees as part of this deal. It's really the major hospitals in the state, including the major Blue Cross Blue Shield carrier. They've been very generous. Participants also do pay expenses for monitoring as well as for drug screens. Next. Our physician workforce, and you've probably seen these statistics before. There's 12,000 physicians with Hawaii licenses, but probably only 3,600 active physicians, and not all of them are full-time. So full-time equivalents, perhaps 3,000. Next. General monitoring requirements, it varies, but most require abstinence from all potential substances of abuse, random observed drug testing, 12-step meetings, worksite monitoring, releases of information. Next. So we're going to use a hypothetical example. This is Dr. A. Dr. A, say, is a 43-year-old anesthesiologist, was referred by the medical executive committee for possible drug diversion. She was, quote, caught on tape, unquote, procuring fentanyl vials for non-patient use. Pharmacy records show above average utilization of fentanyl in surgical procedures compared to her peers. There had been multiple complaints from hospital staff and peers that she seemed intoxicated and displayed erratic behavior at work. A urine drug screen on site was positive for opioids. Dr. A initially denied allegations, but agreed to meet with Pu'ulu Lapa'au as a condition of maintaining her privileges. As an aside, if some of you watch, I think this new ER show called PITT that is streaming, there was a recent episode that presented I think it was a ER physician who had was doing drug diversion. And the writers did consult with the Pennsylvania Physicians Health Program to help create that episode. Next. Dr. A, the Pu'ulu Lapa'au medical staff, so that would be Dr. Guff, met with Dr. A for presumed substance use disorder. Evaluation options, releases were signed. She was formally diagnosed with opioid use disorder and referred for specialty treatment. Next. On admission to a residential treatment center, Dr. A was detoxed and placed in a cohort with other healthcare workers. She spent a total of 90 days in the residential unit, 60 days inpatient, and transferred to step down for 30 days. Her husband was able to come to a family support weekend, and she was able to visit home for a few days. Upon discharge, the treatment center recommended she initiate a monitoring agreement with Pu'ulu Lapa'au, engage with mental health treatment and an intensive outpatient program, intramuscular naltrexone, and to remain off work for 1 month. Next. Dr. A's initial requirements were 4 random drug screens per month, 7 12-step based meetings per week, obtain a sponsor, regular meetings with the medical director, intensive outpatient treatment, mental health treatment with a provider with addiction credentials, remain off work until cleared. Next. Dr. A returned to work part-time after 1 month and gradually returned to work full-time 3 months after discharge. Her worksite monitor, who was chief of her department, reported good work and no indication of substance use. Pharmacy reported appropriate use and wastage. She received positive reports from IOP and mental health provider. Dr. A was discharged successfully from intensive outpatient program after 6 months. Naltrexone was discontinued. Next. 18 months into her contract, Dr. A forgot to check in with the lab and missed a scheduled urine drug test. Dr. A was ordered to immediately cease practice and referred for reevaluation of her recovery status. Employer and worksite monitor were immediately notified. Drug screens were increased to 4 times a month. Next. Examples of noncompliance. Drug screening irregularities include positive tests for substances, missed tests, diluted urine, not attending the required number of 12-step meetings, not meeting with the medical director or board of directors, not meeting with the worksite monitor, and refusal to follow recommendations. Next. Potential actions. Ordered to cease practice, reevaluation of sobriety compliance status, change in monitoring requirements, notification of third-party organizations, including various boards in this state, extension of the monitoring agreement. Next. Dr. A, given her overall strong record of monitoring, the reevaluation determined no relapse. There was to be continued increased drug screening, started quarterly nail collections. Now in year 4, no further compliance issues. Next. Monitoring is hard. It is expensive, it's time consuming, it's anxiety provoking, it's embarrassing. There's always the stigma piece and limited confidentiality. Next. But monitoring absolutely does work. There was a study done of 904 physicians monitored for substance use disorders in 16 state physicians' health programs. 78% of participants were licensed and working at the end of a 5-year monitoring period. Next. The secret sauce. Well, there is zero tolerance for alcohol or other substances of abuse. Thorough evaluation and individualized treatment, prolonged frequent random testing for substances, effective use of leverage, swift, certain, and meaningful consequences for substance use or noncompliance, lifelong recovery rooted in 12-step fellowship. Next. benefits to participation, and you can see maintaining sobriety, job security, restoring healthy relationships, managing legal as well as malpractice issues. Next. Participant views, 45% very satisfied with the PHP, 33% satisfied. And you can see the statistics here, all reporting dissatisfaction were currently in monitoring or had contracts extended at least once. Recommend PHP involvement to a colleague, 93% responded affirmatively. The remaining were currently under contract. Next. We do also have a supportive case management program, which is completely confidential. Next. Dr. Guff is the main person in charge of this program, and anyone can call, any licensed healthcare provider can call, and she'll speak to you. So the issue of burnout, which is pretty common in this country, as you've probably seen in the media, 400 physicians commit suicide every year. Compared to the general population, the suicide rate for male physicians is 40% higher and 130% higher with women physicians. 8 to 10% of healthcare workers suffer from substance use disorders. Over 50% of physicians exhibit symptoms of burnout. If these are not addressed, they could lead to serious problems, including inappropriate behaviors in the workplace, job dissatisfaction, substance use, abuse, early withdrawal from practice, and in some cases, suicide. The cost to the community includes a reduced number of available healthcare providers. The cost to employers can be very high in terms of inefficiencies, increased error rates, and replacing experienced professionals. And obviously, it's very expensive to replace even just one physician or healthcare provider. Next. Barriers to standard monitoring. Oh, I think I did that already. Well, it's the same list. It is very expensive, time-consuming. But if you qualify for this program, you would not require monitoring. Next. The supportive case management, it's really a model for primary prevention. You know, as we had mentioned at the beginning, what do you do for self-care? It's really important for all of us to think about what we do for self-care, because and I'm sure all of you are involved in health as a healthcare provider, and you're probably always thinking about caring for other people and not enough thinking about caring for yourself. So this is a model for primary prevention. As I mentioned before, Dr. Guff is always available to you, and it's confidential, it's voluntary, it's non-disciplinary, and there's no cost for self-referral or at all to your employer. Next. Supportive case management, referral source, self-referral is preferred. Sometimes people are referred by their employers. Reasons for referral: signs or symptom of depression or burnout, work-life imbalance, behavioral concerns. Perhaps someone is rude at the nursing station on a regular basis, and they hadn't been that way before. Exclusions include severe medical mental health disorders, substance use disorder, regulatory agency involvement, or legal issues. Next. So the process, you would be, if you call, you'd be evaluated by our medical director, who's Dr. Guff. She would have informal meetings, as well as educational sessions with yourself, and she would probably refer to outside treatment services, which would include perhaps the EAP, for which your employer pays for, professional coaching, mindfulness programs, medical psychological treatment, as well as formal assessment and monitoring service. And then she would have a maintenance plan. Next. So this is the listing of who's involved in Pu'ulu Lapa'au. I'd be happy to answer any questions.